that feeling of being winded after a short walk, the kind of breathlessness that really hangs around. We often just chalk it up to fitness.
Or getting older.
Exactly.
Yeah.
But what if it's, well, a sign of something deeper going on in your lungs? Today, we're diving into Idiopathic Pulmonary Fibrosis, or IPF. It's sort of like a silent thief, gradually stiffening and scarring your lungs, making each breath, well, a little bit harder than the last.
It really is.
So our mission here is to pull out the essential knowledge about IPF from our sources, what it actually is, the puzzle of where it comes from, how doctors spot it, and what can be done, all in a way that's clear and hopefully sticks with you.
Sounds good. Let's maybe start with the name itself, idiopathic pulmonary fibrosis.
Great. Break that down.
Okay. Idiopathic, as you probably know, means we don't have a clear answer to the why. There's no single known cause.
Okay.
Pulmonary obviously points to the lungs, and fibrosis, that's the key problem. Scarring and thickening of the lung tissue.
Scarring. So that affects how they work.
Yeah, absolutely. This scarring makes the lungs lose their stretchiness, their elasticity, and it really hinders their ability to get oxygen into your bloodstream effectively.
I see.
And it's worth mentioning, IPF falls under this bigger umbrella category of lung conditions called diffuse parenchymal lung diseases. Lots of different types, but our focus today is specifically on IPF, the idiopathic one.
So if IPS is the one where we don't know the cause, what clues do we have? What might be triggering this scarring process?
Well, that's the million-dollar question, isn't it? The main theory right now is that it's likely a combination of genetic factors, maybe a predisposition, and then certain environmental exposures.
Nature and nurture, sort of.
Kind of, yeah. Think of it like your lungs might have a genetic setup that makes them a bit more vulnerable, and then something in the environment triggers the fibrosis process.
Any specifics on those triggers?
Sure. On the genetic side, researchers have found links to certain gene mutations. Some involve genes that code for surfactant, that substance that keeps the tiny air sacs open, and also genes related to telomerase, which is involved in how cells age and repair themselves.
Interesting. And environmentally?
Environmentally, smoking is a big one, a strong link, especially with a history of more than 20 pack years.
Okay, smoking. What else?
Then there are occupational exposures, things like asbestos, coal dust, silica, even exposure to things like bird proteins, from pigeons, or certain molds can sometimes be implicated.
Wow, really? Birds?
Yeah, sometimes. And certain medications too, like Nitrofurantoin, which is an antibiotic, and Amiodarone, a heart rhythm drug, have been linked in some cases.
Right.
Oh, and one other point, it often helps doctors figure things out. The fibrosis in IPF typically starts down in the lower parts of the lungs, lower zone fibrosis.
Yeah, lower zones. So who is most likely to actually develop IPF? What are the big risk factors we should know about?
Age is definitely a major one. IPF becomes much more common in people over 50.
Okay, 50 plus.
And the smoking link, as we just said, is really significant. A family history of IPF also bumps up the risk, which points back to that genetic component.
Makes sense.
And interestingly, it is diagnosed more often in men than in women.
Okay.
Then occupationally and environmentally, besides smoking, exposure to silica dust, asbestos, heavy metals, even things like pigeon breeding or exposure to contaminated air conditioning or ventilation systems have been flagged as risk factors.
All right. It's a whole range of things.
Yeah, and there's also some emerging evidence looking at things like chronic viral infections, maybe Hep C or Epstein-Barr virus, and even chronic acid reflux, where tiny amounts of stomach acid might get into the airways microaspiration.
Okay, microaspiration. So we know who's more at risk, but down at the cellular level, what's actually going wrong inside the lungs?
Right, the pathophysiology. Basically, the fundamental issue seems to be repeated tiny injuries to the delicate lung tissue, the alveoli.
Microscopic injuries.
Exactly. And on IPF, the body's normal healing process goes wrong.
Yeah.
Instead of properly repairing the damage, the body lays down excessive amounts of scar tissue. That's the fibrosis.
And that scar tissue causes the problems.
Precisely. It thickens and stiffens the walls of the air sacs. This makes it harder for oxygen to pass from the air you breathe into your blood and harder for carbon dioxide to get out. And because it's progressive, this scarring just keeps building up over time, leading to those symptoms and the drop in lung function.
Okay, that makes sense. But, shortness of breath.
Yeah.
Lots of things can cause that. How do doctors tell IPF apart from everything else? What's the differential diagnosis look like?
That's a really crucial point. Diagnosing IPF isn't always straightforward because the symptoms, especially early on, can mimic so many other conditions.
Like what, for example?
Well, Common things being common, you have to consider heart failure first, often. And COPD, chronic obstructive pulmonary disease, that's a
Yeah.
big one. But
Right.
then there are other lung diseases too, like sarcoidosis, maybe a pulmonary embolism, a blood clot in the lung, even lung cancer or hypersensitivity pneumonitis, which is inflammation from inhaling something like mold or bird dust.
So quite a list already.
Oh, yeah. And infections like pneumonia, occupational diseases like asbestosis if there's been exposure, and other types of interstitial lung disease too, perhaps linked to connective tissue diseases like rheumatoid arthritis or scleroderma.
So autoimmune conditions can be linked too.
Sometimes, yeah. IPF can occasionally occur alongside things like thyroid disease, systemic sclerosis, rheumatoid arthritis, even lupus or autoimmune liver disease. So doctors need to look for those connections as well. It's a complex picture.
It definitely sounds it. So how common is IPF, actually? What do the numbers tell us?
Well, in the UK, the estimates are around 5 to 15 cases per 100,000 people.
Okay, so not super common, but not vanishingly rare either.
Exactly. And it's much more common in older adults, especially people over 70. And as we mentioned, it's more frequent in men.
Right.
It is, in fact, the most common type of interstitial lung disease here in the UK. The incidence, so the number of new cases each year, is around 7.44 per 100,000.
Gotcha.
And again, that typical age range is often 50 to 70. More common in smokers and also more common in people who already have COPD.
Interesting overlap with COPD.
Yeah. And while most cases are sporadic, there are familial clusters in less than 5% of cases. But genetic factors are thought to play some role in maybe up to 30% of all patients, even those without a clear family history.
Okay. So let's talk about how it presents. What are the kind of classic signs and symptoms that would make a doctor think, could this be IPF? What should you, the listener, maybe be aware of?
The two big ones, the most common presenting symptoms, are a gradual worsening of shortness of breath, particularly when you're doing something active that's the progressive exertional dyspnea.
Gets worse over time with activity.
Exactly. And the other is a persistent, dry, hacking cough. It just lingers. Fatigue is also really common. People just feel wiped out.
Okay, breathlessness, dry cough, fatigue, anything else?
On examination, when a doctor listens to the chest with a stethoscope, a key finding is often these fine crackling sounds during inhalation, usually in both lungs at the bases, sometimes described as sounding like Velcro being pulled apart.
Velcro crackles. I've heard that term.
That's the one. Another physical sign you might see is finger clubbing, where the tips of the fingers get wider and the nails curve around them.
Okay.
So doctors will put this together. Is the patient over 45? Have they had this persistent breathlessness on exertion? Maybe the spirometry, the lung function test is abnormal,
Yeah.
often showing a restrictive pattern, though sometimes it can look obstructive or even normal initially.
Right.
And sometimes there are more general symptoms like unexplained weight loss, maybe some achy joints or muscles, sometimes flu-like feelings. And obstructive sleep apnea is also quite common in these patients.
And what about in the later stages?
In more advanced IPF, you might see someone breathing much faster, tachypnea, maybe cyanosis, which is that bluish tinge to the skin or lips from low oxygen, and eventually signs of strain on the right side of the heart called cor pulmonale, or even right heart failure.
So seeing these features, especially if someone has those risk factors we talked about, smoking, age, exposures, that should definitely raise the alarm for IPF.
Absolutely. That's when further investigation is needed.
Okay, so if IPF is suspected, how is it actually confirmed? What tests are involved?
It's usually a combination approach. Spirometry, as we mentioned, is key. It often shows what's called a restrictive pattern.
Explain that again.
Yeah, so restrictive means the total amount of air the lungs can hold is reduced. So the forced vital capacity, or FVC, how much air you can blow out forcefully after a deep breath, is decreased. But the ratio of how much you can blow out in the first second compared to the total, the FEV1 FVC ratio, is often normal or even increased because the airways themselves aren't necessarily blocked. The lungs just can't expand fully.
Got it. Less volume, but airflow speed is okay relative to that volume.
Pretty much. We also look at gas exchange, how well oxygen gets into the blood. That's often measured by the transfer factor, or TLCO, and that's typically reduced in IPF.
Okay. What about imaging?
A standard chest X-ray might show some clues like bilateral interstitial shadowing, sort of hazy lines, maybe small irregular opacities, especially at the lung bases. Later on, you might see that honeycombing pattern.
But X-ray isn't the main thing.
No, the real investigation of choice is a high-resolution CT scan. An HRCT.
That's the detailed one.
Right. It gives a much clearer picture. And on HRCT, we look for a specific pattern called usual interstitial pneumonia, or UIP.
UIP. What does that look like?
UIP has characteristic features. The changes are mainly at the bases and the edges of the lungs near the pleura. You see a reticular pattern, like a fine net. You often see honeycombing, which looks like clusters of little cysts. And importantly, you don't see features that would strongly suggest a different diagnosis.
Okay, so HRCT is key. Any blood tests?
Blood tests are done partly to rule out other things. For example, testing for autoantibodies like ANA and rheumatoid factor. They can sometimes be positive in IPF, maybe ANA in about 30%, rheumatoid factor in 10%, but usually at low levels. It helps build the picture.
So the process is detailed history, first exposures, family history, meds.
Exactly. Then a thorough clinical exam, listening for those crackles, looking for clubbing, then blood tests, chest, X-ray, and lung function tests, including spirometry and gas transfer.
And then usually the HRCT.
Usually, yes. If the HRCT shows that classic UIP pattern in the right clinical context, that's often enough for diagnosis. But if the picture is less clear,
Then what?
then further tests might be needed. Maybe a bronchoalveolar lavage, or BAL, where they wash out a small part of the lung via a scope and look at the cells. Or sometimes a lung biopsy is required, either taking small samples through the bronchoscope or, less commonly now, a surgical lung biopsy.
Right, to get a tissue sample.
Okay.
So once someone is diagnosed with IPF, what happens next? What are the management strategies? Is there anything to actually stop or reverse the scarring?
That's the tough part. Currently, there's no cure for IPF. We can't reverse the scarring that's already there.
Okay.
So the main goals of management are really about slowing down the rate at which the disease progresses, relieving the symptoms as much as possible, and maintaining or improving the person's quality of life.
How do you go about that?
A really important part right from diagnosis is pulmonary rehabilitation.
Rehab. What does that involve?
It's basically a program combining tailored exercise training with education about the condition, breathing techniques, energy conservation, that sort of thing.
Yeah.
And it should be ongoing, repeated at intervals.
Okay. Exercise and education.
Yes. And general health measures are vital too. Staying as physically active as possible within your limits, maintaining a healthy weight, absolutely stopping smoking if the person still smokes.
Crucial.
And getting vaccinated against influenza and pneumococcal pneumonia is really important to prevent infections.
Makes sense. Anything else supportive?
Yes, for patients whose oxygen levels drop significantly, especially with activity, supplemental oxygen therapy can make a big difference to symptoms and function.
Right.
Physiotherapy can help with airway clearance if cough is productive, though it's often dry. And interestingly, medications called proton pump inhibitors, or PPIs, which reduce stomach acid, are often considered.
Why PPIs? Because of that microaspiration link. Yeah.
Potentially, yeah. The thinking is it might reduce any lung irritation from reflux. And then in very advanced end-stage disease, sometimes low-dose opiates might be used carefully to help manage a really excessive or distressing cough.
Okay. What about specific drugs that target the fibrosis itself?
Right. There are currently 2 main medications licensed and shown to slow the progression of IPF. They don't stop it, but they can slow the rate of decline in lung function.
And what are they called?
They are pirfenidone and nintedanib. These are always started and monitored under specialist care.
Okay. Pirfenidone and nintedanib. How do they work generally?
Their exact mechanisms are complex, but broadly they interfere with some of the biological pathways involved in the formation of scar tissue.
And who gets them?
I see. The guideline body in the UK generally recommends them for people whose lung function, measured by that FVC, is between 50% and 80% of the predicted value.
So a specific window of severity.
Typically, yes. For pirfenidone, for example, treatment would usually be stopped if the FVC drops by 10% or more in absolute terms over a 12-month period, suggesting it's not effectively slowing things down enough.
Right.
Nintedanib has similar NICE approval and similar criteria for use. Both have been shown to have a comparable effect in slowing that FVC decline. But it's really important to stress, neither is a cure. The disease still progresses, just hopefully more slowly.
That's a key point. Slowing, not stopping, or reversing. Is surgery ever an option?
Yes, for some people. A lung transplant can be considered for carefully selected individuals, usually younger patients whose disease is progressing despite medical therapy.
Lung transplant, that's major surgery.
It absolutely is. But for the right patient, it can significantly improve survival. Actually, IPF is one of the most common reasons people get lung transplants globally.
Wow.
But the selection process is rigorous. There are specific criteria about lung function decline and oxygen levels that usually trigger a referral to a transplant center for evaluation.
Okay. Any other treatments? What about steroids?
Corticosteroids, like prednisolone, might sometimes be used short-term to treat an acute exacerbation, a sudden worsening of symptoms, but they aren't recommended as a long-term maintenance treatment for IPF itself.
Right.
And similarly, treatment specifically for pulmonary hypertension, which can be a complication, isn't routinely recommended unless there are very specific reasons based on individual assessment, often in a specialist center. Oh, and one editor's note from our sources mentioned that nintedanib might sometimes be considered even if the FVC is above 80%, if the patient is still showing evidence of disease progression.
Ah, okay. So some flexibility there potentially. So with all this, was a typical long-term outlook for someone diagnosed with IPF, the prognosis?
Unfortunately, despite the treatments we have to slow progression, the overall prognosis for IPF remains generally poor. The median survival time from diagnosis is still estimated to be around 3 to 5 years.
3 to 5 years. That's quite sobering.
It is. However, it's really important to remember that the course of the disease varies a lot between individuals. Some people have a much slower decline over many more years. But sadly, respiratory failure is the most common cause of death.
Understood. And are there common complications people might face along the way?
Yes, several complications can arise. We mentioned acute exacerbations, those sudden worsenings, which can be serious. Pulmonary hypertension, high blood pressure in the lung arteries can develop as the disease progresses.
Okay.
People with IPF are also more prone to respiratory infections like pneumonia or bronchitis.
Makes sense. The lungs are already compromised.
Exactly. And then there are issues related to advanced lung disease, generally worsening respiratory failure, sometimes a collapsed lung, which is called a pneumothorax. There's also an increased risk of developing lung cancer compared to the general population.
Really? Lung cancer too?
Yes. And also potentially higher risks of pulmonary embolism and coronary artery disease. So regular monitoring by the healthcare team is crucial to watch for and manage these potential complications promptly.
Definitely sounds like close follow-up is essential. Okay, so just to quickly recap our deep dive into idiopathic pulmonary fibrosis.
Yeah, let's pull it together.
It's this chronic progressive lung disease where you get scarring fibrosis, but we don't know the specific cause, hence idiopathic.
Right. Likely a mix of genetic susceptibility and environmental triggers like smoking or certain dusts.
Presents typically with worsening shortness of breath on activity, a dry cough, maybe fatigue, and those Velcro crackles on listening to the chest.
Diagnosis leans heavily on lung function tests, showing a restrictive pattern, and especially a high-resolution CT scan looking for that UIP pattern. Sometimes a biopsy is needed.
And management. No cure yet, but the focus is on slowing it down with meds like pirfenidone or nintedanib.
Alongside crucial supportive care like pulmonary rehab, oxygen if needed, vaccinations, and smoking cessation.
Lung transplant is an option for some selected patients, but the overall prognosis is serious, often just 3 to 5 years median survival.
That's the picture, unfortunately.
It's a really complex condition. Hopefully this dive has given you a clearer understanding. If you do want to dig deeper, or perhaps refresh this for exam purposes, remember to check out resources like passthemsra.com and freemsra.com.
Yeah, good resources there. And research is ongoing, always searching for better ways to understand and treat IPF, offering hope for the future.
Absolutely. A lot more to learn.